Hi everyone, welcome back to another day of our free NCLEX review. We are on day 58 out of the 90 days, and we are welcoming everyone to this class today. I hope that you're going to hang tight with us up until the end of the lecture discussion today. And for those who are newbies to the channel, we are welcoming you as well, and we are inviting you to enroll into our NCLEX course via www.stancoast.NCLEXcoaching.com, and also take note about the description box below. We have the link there for you to check out. We have our library of on-demand videos plus the animated videos, and this is something that you can access for the entire 6 months, and along with the 200 NGN test questions and 3,000 NCLEX test questions, we also have the animated videos and also the 200 hours of on-demand videos updated as well. So kindly do that. Check in our description box, and we are also inviting you to like and subscribe to our channel. So if you find this video helpful, then we would love to have you share this video as well to your friends who are reviewing for the NCLEX. And today we'll be focusing into our new topic. Today we'll be dealing with the herniated intervertebral disc, which is basically a continuation of our topic under the neurology concepts. All right, so I hope that you will be learning a lot today. So let's get right into the topic. Hello, Adobe. Hi, Mary. All right, guys, let's talk about the herniated intervertebral disc. So what is this condition? Well, this is a problem wherein there is going to be a rupture, which is actually occurring in the nucleus of the disc, which actually will push into the surrounding annulus, or what we call as the fibrous ring around the disc. And this will lead into the compression of the nerve. Okay, so this is what we have as the rupture of the disc. Now, this herniation will happen at any level of the spine. It could be the cervical, could be the lumbar, sacral, thoracic, and the resulting pressure on the spinal nerve roots or the spinal cord will cause the patient to have severe and it can also become chronic. So it could be either acute or it can be chronic, and the pain here will be recurring in the legs and also in the backside of the body. Hello, Felix. Hello, Joyfully. And Josue, Theodore, welcome. And also Joyce. Welcome, guys. Now, again, the herniation can happen at any level of the spine. And again, the resulting pressure on the spinal nerve roots and also on the spinal cord can lead into either the acute or it could be the chronic recurring pain in the lower extremities, or it could be the upper extremities as well. Now, let's do a quick review here about the anatomy of the intervertebral disc. Okay, so this is your structure that you should be looking at right now. So this is where the intervertebral disc actually is, and this is going to consist with that cartilaginous plate that actually has that gel-like substance in the center. So right here, this is what we call as the nucleus pulposus. Okay, so again, this is a gel-like structure. And this is going to be surrounded by the layer, which is a fibrous type of a layer. And this is what we call as the annulus fibrosus. Now, guys, take note that with the different anatomy structures here, take note about the other important structures like the Cauda equina. Okay, so that's right there, pertaining to that oval shape section. And this is what we call as the spinous process right here, this protruding bony structure. And then we also have the lamina, which is basically this side right here or this side. So don't forget about these important structures. Again, Our main actor here is the nucleus pulposus, which is basically at the center, which is the pink colored. All right. So again, this is the gel-like substance that can possibly herniate, including also the annulus. Now let's talk about the different risk factors why the herniated intervertebral disc can happen. There are so many, guys. And so we have here, hello May, hello Anita. The disease process will include, of course, with the following risk factors. One of those will be the aging, wherein there is going to be a degeneration, because as people will age, the intervertebral disc can also lose its water content. Again, the disc can lose its water content, and this will become less flexible, and they will be prone to tearing. They can also rupture with minor strain or even movement, twisting, bending. And again, aging is a huge factor in the herniation. Now let's talk about another one, which is trauma. This is going to happen whenever there is an incident, let's say falls, could be accidents in the car, could be sudden impacts, maybe whiplash, and or even worse than that, it can really cause the disc to herniate by causing that excessive force to the spine. Hello, Marie-Flore. Now, aside from the trauma, falls, hello, AJ, impact, right? So don't forget about the aging, trauma, and we have another risk factor, which is basically the congenital predisposition. What is this? Well, people sometimes can be born with those genetic predisposition that could possibly make their intervertebral disc more susceptible to herniation. So they will have higher incidence as to this condition. Now, another would be those biochemical factors, which are known to be done more frequently, especially with twisting. Could be those repetitive motions, especially those jobs or occupations that might involve these actions, right? Maybe lifting those heavy objects, bending. Those transport people are really prone to getting this. Even nurses, yes, nurses are really prone to developing the intervertebral disc. No kidding, especially if you're on your own and you're probably unable to get some help. Yeah, you are really at risk to developing the herniation, guys. And good thing that I did not go that far. I had low back injuries in the past, handling patients, heavy patients, even with some help. Yeah, even with body mechanics. Also, some sedentary lifestyle, right? Or work. Those jobs that would require prolonged sitting, that's another risk factor. This can lead to poor posture and also weakened muscles. And again, the problems inside the disc can also occur right here. Hello, Ukamaka Ezegwe. Welcome. Now, another risk factor here is obesity. Well, excess weight can actually put additional strain into the body and specifically into the spine, wherein there's going to be much more rapid degeneration and herniation. And we also have our popular smoking, wherein this will reduce the blood flow to the disc and will also speed up the degeneration, and it can weaken the structure integrity of the disc. And again, this will make the herniation at a higher rate. Okay. Now, what do you think would be the prevalence and the causes of the herniated disc? Well, most of the time, this is going to occur mostly in the lumbar area, and also the lumbosacral region of the spine. Okay. So basically here, the most affected section of the body here, especially the lumbar and lumbosacral spine, are within the L4, the L5 disc space. And this is, again, the frequent site. And the herniation basically is that movement. How do you find herniation? This is the movement of that gel-like structure, okay? wherein it is going to be out of that anatomical position. It's no longer in its proper position. And we know that the gel-like structure is actually going to cushion that area, right? And as if you have paid attention into the previous section right here in our picture, again, this can lead to the rupture of the disc itself, okay? The nucleus of the disc is pushing through the surrounding annulus. This is the fibrous section that is going to be pushed out as well, all right? So not just being pushed, but it can also lead to the compression of those nerves that are involved in the proximity. Now let's go back into that section right here about the location. Now again, I'm mentioning right now that the most common site is the L4 and the L5, basically in the lumbar area. And again, the most common cause here is the flexion injury. It could be the bending below the waist. And also when a person may have a cervical type of injury as well, or herniation into the cervical disc. But this is not as common compared to the lumbar disc, okay? And this is going to occur mostly with the adult group, especially like greater than 45 years old or older. And take note, guys, that whenever there is a herniation, the impact here will actually be on the spinal nerve root, okay? What's going on with my pen here? Let me just make sure I have that. Okay, here we go. So whenever there is herniation of the gel-like structure, this can now push, or the annulus as well, it can push forward into the spinal nerve root, and it can cause degeneration. And again, whenever there is pushing of those important structures, this can impinge nerves or could be the spinal cord itself. And we'll be talking more about the progression here, okay? Now, the symptoms that we will be expecting here will be varied, and also it depends on to the progression of the herniation. Again, it can be mild, or it could be severe, or it can really impair the overall function of our patient, okay? Now, guys, let's talk about the section right here. Let's take a look into this photo real quick. So again, this is our gel-like structure where you see the pink color, and then we have the vertebral body surrounding the annulus as well. So take a look here. Whenever there is herniation, it's actually moving forward, pushing the other structure right here. Whenever there is that herniation, it can compress the nerve root. And this is the time when the person will manifest those numbness, paresthesias, could be weakening of the muscle tone, could lead to some impairment in their motor function as well. Okay, so we will talk about the different levels as well as we go along in our lecture this time. As far as the herniation, it can progress as well. Since this is a degenerative process, it can take between months to years as well, and it can develop into acute and chronic symptoms. Now let's talk about the different assessment findings here, because the assessments here will depend on the location. It can happen in the cervical area, it could happen in the lumbar, thoracic, or the sacral, okay? Now, the assessment findings here, we'll start with the cervical herniation. So what do you expect if the problem will affect the cervical area? Well, take note, guys, that this will be manifested commonly as a pain and also stiffness into the neck area. And it can also radiate into those following spots: the scapula, the shoulder blades, the top of the shoulders. And aside from that, they will also have those numbness, tingling sensation, paresthesias, those pins and needles, This will affect mostly on the upper extremity since we are talking about the cervical herniation. Again, the numbness, the paresthesias will occur mostly in the upper extremities, and the pain will be there as well. Now, taking a look into the weakness whenever there is a cervical intervertebral disc, again, this is more noticeable in the upper extremities as well. Now, as we transition into the lumbar herniation, take note, guys, that the manifestations here will be mostly towards the lower back. The patient will be complaining of that back pain, and the pain will also radiate into the legs. This is what we refer to as the sciatica. And the pain, aside from that one, the patient will also have sensory, also motor dysfunction, and they will end up with an abnormal posture because they are in such pain that they just want to get into that comfortable position. But again, their posture here is actually impaired. Now, there's also that paresthesia. There is also reflex impairment and significant weakness into the lower extremities. And when you are testing this patient, there is what we call as the positive straight leg raise testing. And how are we going to do this? Well, this is basically going to occur whenever there is that the patient is actually going to be put into a supine position, right? And then the examiner will start slowly elevating the patient's leg at an increasing angle while we are keeping that leg straight at the knee joint. So make sure the patient, again, is in a supine position, and then you are going to elevate slowly the patient's leg and make sure that you are keeping that leg extended. Do not let it flex. Now, it will be positive if when you are doing the elevation slowly, the patient will have that typical pain and they will experience that paresthesia. They will have that numbness, tingling sensation into that particular extremity. So take note, guys, about this positive straight leg raise examination. So that's one of the assessment skill that you can use in this patient. Now, take note also regarding the assessment finding. Here we have in the Cauda equina syndrome, which is much more of an emergency. Take note, guys, that with the Cauda equina syndrome or the Cauda equina, this is basically a bundle of the nerves in the spinal cord and also the nerve roots, and they are actually originating in the lower end of the spinal cord, the conus medullaris. And they're also going to extend down to the lumbar and the sacral regions of the spine. And with this is actually going to resemble as a horse tail. So I think I have that in my photo right here. Cauda equina. Okay. Let me zoom in that area. Okay. So whenever there is a injury, especially into that site, whenever there is a significant compression or damage to the nerves, typically in the lumbar spine, okay? We're talking about the lumbar spine right now. And this is something that can happen mostly between the L4 and the sacral 1. Again, between L4 and S1 levels. So this can also include the herniation of the disc. It can also include the spinal stenosis. It can also be caused by tumors, maybe infections or trauma. But then again, with a Cauda equina, the patient will manifest that severe lower back pain. They will also have that sciatica. They will also have that progressive motor and sensory loss of the lower extremities. Now here, guys, take note that they will also manifest that saddle anesthesia, wherein they will have a loss of sensation into the perineal area. Okay, so please take note about the saddle anesthesia. There will be a loss of sensation in the perineal area. The patient will also manifest those incontinence, both bowel and bladder. and including the sexual dysfunction. Now, take note, guys, that again, the nerve compression is focused into, again, the L1 up until, or between the L4 and also the S1 levels. So please take note of that. Let me just check real quick. Okay, I think we're good. Now, let's move forward here regarding the discussion about the Cauda equina syndrome. This is a very progressive motor sensory loss, and again, it will be manifested as severe pain in this patient, and then they will have that saddle anesthesia. Please don't forget that complaint. The patient will have loss of sensation in the perineal area. That's what we call a saddle anesthesia. Again, they will have bowel bladder incontinence, and also an impairment in the sexual function. Now let's talk about the different treatments here. When we are going to approach this, especially in the acute or in the acute onset of the herniation. Okay, so we will encounter a patient that might have this acute cervical or lumbar radiculopathies. And if we are going to define what a radiculopathy is, this is basically that involvement of the nerve root in the cervical spine, or it could involve the nerve root of the lumbar spine. So what are those manifestations basically in the radiculopathies? Well, again, they will manifest those pain according to the levels, right? If they have cervical radiculopathy, they will have that neck pain. There will be radiation to the shoulder, the arm, or the hand. They will also have the numbness, tingling sensation, the weakness in the affected extremities, especially the upper extremities. And if they have the lumbar radiculopathy, they will also manifest that back pain. And again, this is going to be experienced more into the lower back, and it will radiate into the lower parts of the body, like the buttocks, the leg, and into the foot as well. And this will also be accompanied by the numbness, tingling, muscle weakness into the lower extremities. Now, guys, please take note about the treatment here, that it can be temporarily treated by bed rest. This is one thing that you should pay attention. Bed rest is needed. About 2 days would be sufficient to at least allow some improvement in about 80% of all patients. Again, this will immobilize the area, the site of the injury. Now, another treatment that we're going to have is the application of the heat or ice. And I know that with, of course, the injury to the site can also cause inflammation, swelling into the site. So we can have that alternation of either heat or ice application in order to alleviate those symptoms. Part of the treatment here will be the administration of the anti-inflammatories. It could be in the form of the non-steroidal anti-inflammatory drugs, or it could be the steroid, which is the prednisone, all oral routes. Now, also with the use of the other medications like the muscle relaxants, we have them as the diazepam, the cyclobenzaprine. Actually, I've used this when I had my back injury, the cyclobenzaprine. That was quite interesting, actually. The effect is so relieving. I was off work for about 2 days after assisting a patient from her bed to the bedside commode, and she did not bear weight, even though I instructed her to bear weight when she was allowed to do so, but she did not. So most of her weight actually fell on me. And so, yeah, that was quite a surprise when that happened. Now, analgesic opioids are very necessary, especially during the acute phase, and the use will probably last for several days or maybe more. It depends upon the severity of the pain. And if applicable, of course, physical therapy is going to be ordered. But then again, guys, please take note, the physical therapy is not recommended during the acute onset, okay? It is only recommended when the patient has already reached that 3 weeks, okay? Because during that period, there is actually a higher chance that there might be some resolution of the inflammation, most of the time, those herniated discs can improve on their own within a few weeks because of the body's natural healing processes. So physical therapy is not going to be very beneficial during the first few days. No, it's not. Although we can recommend this, or maybe the doctor will order this after that period. But then again, it will not be beneficial during the acute stage. Now, again, the reason for that, it's because the inflammation can decrease within that duration. And again, because of the body's natural healing processes. And so the inflammation here, or let's say the herniated material, can also be reabsorbed. So there might be a reduction in the pressure on the nerves. Now, what we're going to need to do here, though, is we're going to have to avoid exacerbation, okay? Again, physical therapy is thought to exacerbate if it is done way too early. So again, it is not recommended. It can exacerbate the stress and also the injury if it's done way too early. Now, take a look into the conservative treatment here. Aside from the physical therapy, there could be a need for the epidural steroid injection, which is basically your anti-inflammatory. And this is something that the interventional radiologist may be able to administer. And this is going to be injected if there is that significant radiculopathy, or if there is now radiation of the pain down to their extremities, and also with a numbness, tingling sensation, those kind of stuff. Now, guys, please take note that not just one treatment would be effective here. It will be a combination of both the non-pharmacologic and pharmacologic treatments. And this is something to be used and expected to be used together for about 4 to 6 weeks as part of the conservative treatment. Okay. Now, let me just talk a little bit here about the bed rest. And the bed rest will basically require a firm mattress. Okay. So the ideal bed for this patient would be a firm mattress. Make sure that it's actually supporting the backside of the patient. It's not, we're not going to allow them to use those very cushiony material because it cannot promote the alignment or the neutralization of the spine. Okay, firm mattress. Okay, so please take note of that. Hello, Ms. Eflian. We also have Monica. Welcome. Now, again, guys, please take note of about the different treatments that we have talk about. This will be all in combination and according to the severity of the pain as well. Now, guys, let's talk about the surgical treatments. We'll breeze through so many. There are so many options according to the severity of the herniation. We have our first surgical treatment, which is basically the discectomy. Some books spell that as D-I-S-C-E-C. Some books would spell that with a K, all right? So this is a procedure basically to decompress the nerve root. So let's just zoom in this real quick right here. So whenever there is that herniation of the disc, look into the top portion of the photo here. Look into the gel-like structure and also the annulus, where it's actually causing forward movement into the nerve root. And this is now going to compress and will put pressure into the spinal nerve. Now, whenever there is that procedure, that discectomy, this is an invasive procedure, of course, consent will be required. There should be explanation by the medical provider or the surgeon to the patient about the risk and the benefits. But then again, this is an invasive procedure. The patient will be required to have some NPO as well before the procedure. And here, with a discectomy, this is going to allow removal of the herniated portion of the intervertebral disc in order to relieve the pressure on the nerve root of the spinal cord. So it could also involve the removal of a portion of the bone in order to relieve the pressure onto the nerve root. Okay. Now, take note, guys, that this is a procedure that will be done under general anesthesia, and there's going to be an incision made over the affected vertebra. And also, the surgeon here will remove the herniated part of the disc and also that bone, like I have said. Now, what is the indication here for the discectomy? Well, it is going to be done whenever there is persistent radicular pain, those radiating pain along the path of the nerve, or maybe they have deficits, maybe they have weakness, numbness, tingling sensation, despite those conservative treatment that we had mentioned earlier, then they're going to possibly have the discectomy. Now, if you're going to ask, what's the benefit about having the discectomy procedure? Well, again, it can relieve the pressure onto the nerve root, which will alleviate the pain. It will alleviate the numbness. It will alleviate the weakness. And the patient here is expected to have a quick recovery within a short hospital stay. Okay, guys, please take note, this is a surgical procedure, so there will be risk involved. There's going to be infection, there's bleeding, nerve damage, and also possible recurrence of disc herniation. Now, if you're going to ask about the recovery, well, most patients here will experience significant pain relief and also some improvement in their function within a few weeks after the procedure. Now, if you're going to ask here, what about physical therapy? Well, that will be recommended as well after the surgical procedure in order to strengthen the back and also to prevent the future issues. And if you're going to ask, what are those nursing actions or post-op nursing care that you should do here? Well, post-operatively, well, you're going to expect that the patient will be having some pain, right? So here, you're going to have to do your assessment, monitoring of the patient's pain. We're going to have to administer them the prescribed analgesics, and also it could be a variety of maybe of the anti-inflammatories, the NSAIDs, could be the opioids. Another thing is we're going to have to worry about the incision site. We definitely need to inspect the surgical site for any signs of infection. And that is huge, guys. Post-operatively, take note about incision, wound care. Infection can set in if we are not being careful with the patient's wound site. Another thing that we need to keep an eye on here would be to check for signs of infection. What are those? Well, of course, if there's going to be redness around the surgical site, if there's swelling, or maybe presence of any kind of discharge, we definitely need to report this to the medical provider. We need to carefully do sterile technique dressing changes as prescribed. It could also involve the administration of the antibiotics to treat the infection. Now, as far as mobility, the medical provider here will recommend early ambulation, and this is to prevent those complications, DVT, and also this will allow much more rapid healing. We're going to have to assist the patient with the turning and also positioning. And we want to make sure that our patient will be turned as a unit, lug rolling, in order to prevent further complications. Now, please take note, guys, this is a surgical procedure that can potentially cause some complications as well. Now, we need to do careful neurovascular assessment. And this will be applicable to the remainder of the surgical procedures that I'll be mentioning later. Again, do your neurovascular assessment. So what are these? We're going to have to check for their circulation in the distal extremity. You also need to check into the patient's sensation in the distal part of the body where the surgical procedure has been done. And also make sure you're checking into the motor function. All right, these are very important. Neurovascular checking. Hello, yes, Yamini. Hello, Ruth. Hello, Monica. And again, these are your nursing assessments or nursing monitoring actions that you should employ whenever you have this patient with this kind of surgical procedure. And not just this, but with the others as well. Other surgical procedures that I'll be mentioning in the next page. Now, as far as education, what would you need to do here for your patient? Well, you are going to instruct your patient to do proper bending mechanics. You're going to instruct them to avoid bending or twisting. And you're also going to emphasize the importance of following those post-op restrictions. And with this patient, post-operatively, you need to emphasize, make sure that they're going to show up for their follow-up appointment with the surgeon to monitor further recovery, and also to assess if they need further interventions, if they probably had developed some complications. So make sure that they're going to show up for that appointment. Now let's talk about another procedure which is very common. This is the laminectomy. So what is this? The laminectomy is actually going to involve the removal of a portion of the vertebra called the lamina. I've showed that picture to you earlier about the anatomy. And with the laminectomy, this is going to provide, or it will create more space for the spinal cord or the nerve, since we are talking about the compression of the nerve root, right? And so in order to relieve the pressure into the nerve root, if it is severe, or if there is severe impairment, now the patient will require that removal of that portion of the vertebra. So let me zoom this in right here. Okay, so you'll see here the structure. And of course, with the laminectomy, this could probably involve the removal a part, or maybe a portion of the lamina will be removed surgically in order to relieve the pressure into the nerve root. Okay, again, the goal of the surgical procedure is basically to remove the pressure onto the nerve root or to the spinal cord. Now, what is involved here when the laminectomy is done? Well, it involves incision, right, into the back. And again, this is a invasive procedure, a major surgical procedure. It will require order. Make sure that the consent is all signed. The patient will be NPO 8 hours at least. With this procedure, the patient will be facing down on the surgical table. Okay? Now, there are so many indications to the laminectomy. It can be used in the herniated intervertebral disc, a severe form of that, or it could be used as to a problem we call the spinal stenosis as well. Now, if you're going to ask about the benefit about the laminectomy, well, again, it can relieve the pressure to the spinal cord and the nerve roots, and it can also allay those symptoms. It can improve those symptoms of pain, numbness, weakness. And since this is a major procedure, there are also risks involved, since there is a removal of the portion of the lamina. Well, what do you think? The spine will become unstable because of that removal of the bone. And there is a possibility that there can be nerve damage as well post-op. And of course, post-op pain will be one of those. Now, if you're going to ask, what's the recovery on this patient with the laminectomy? It will vary, guys. It could last into several weeks, or it could be months. And depending into the progression of our patient's physical therapy and also the rehab, then yeah, again, the recovery will vary from one person to the next. But then again, most oftentimes the patient will have great improvement of their symptoms after the surgical procedure. They might also have some residual symptoms, could be minimal, right? Now, if you're going to ask about the pain post-op, well, that's going to be part of our care. We're going to definitely control the pain, make sure that we are administering them those medications as prescribed, opioids, anti-inflammatory, corticosteroids, also the application of the cold ice packs or heat application. And another thing, since this is going to involve incision, we're going to also monitor for the incision right here. Monitor for signs of infection. That's another biggie post-op care. We want to make sure we are looking into the site for any signs of infection, redness, swelling, drainage from the incision site. We want to make sure that we are changing the dressing. We will be using aseptic techniques. Now, as far as the mobility, how are we going to deal with the patient's movement? Well, we're going to encourage movement and ambulation as tolerated or as prescribed by the medical provider. definitely this patient is a fall risk, a huge fall risk. The recovery will last for weeks and months. And again, the patient will require lots of neurovascular monitoring. This is another key nursing action, neurovascular monitoring. So again, we're going to have to focus into the patient's circulation, sensation, and motor function. We're going to have to check our patient about their signs of cord compression, or if there is going to be worsening of their neurofunction, maybe weakness, numbness, bowel bladder dysfunctions. Those are things that we will be keeping an eye on. Now, as far as the activity, we are going to educate the patient about the restrictions, the signs of the complication, post-op exercises. Another thing is we're going to have to give them instruction, especially instructions that will be given into the care provider or caregiver rather, or their family member that will be involved into doing the wound care, and also the pain management at home. And also we're going to have to give them education on what manifestations that they need to pay attention to so they can get medical attention. They can call the provider as soon as possible. Now let's move forward to another surgical procedure, which is on the spinal fusion. This is also a common surgical intervention wherein there is going to be placement of the or there is going to be stabilization of the vertebra, wherein there's going to be joining of two or more vertebrae. So take a look into the photo right here. Joining of the vertebra. Take a look. Two. This is what we call as fusion. Okay. Take a look into that appliance right here, applied into the vertebra. There's that rod, also placement of the screw. Okay. And then we also have the placement of the artificial disc in place. Now, this is another procedure that will involve creation of the incision in order to access the spine, and there will be placement of bone graft or implants. Okay, bone graft and implantation with that artificial disc. Again, this will also involve the placement of the screws and rods. I've dealt with so many patients with fusion, and especially with motor vehicular accidents that they had in their past medical history. Yeah, there's so much pain involved. Even after the surgical procedure, they will still have those residual pain. They're going to be chronic users of those opioid medications as well. Again, back to the procedure here with the spinal fusion. Again, this will involve the implantation of that artificial disc, also the placement of that screw rods, and this is going to stabilize the area, okay, to fuse the affected vertebra to somewhat immobilize that area to prevent pain or to reduce the pain. Now, what are the benefits for the spinal fusion? Again, this will provide stability to the spine. It can also relieve pain caused by the instability or maybe the degenerative conditions. And this is going to have some risk involved. The same with the laminectomy. There's also some risks of having the infection, or it could be non-union of the fusion site. Non-union of the fusion site. Those are possible risks and could be leading into maybe degeneration or wear and tear on the disc next to the fused segments. So maybe this is the area that has been fixed, but possibly it can also affect the other disc in the different section. So that's another risk involved. Now, if you're going to ask about the recovery in a patient that has a spinal fusion, it can require about several months. They will require physical therapy, intensive physical therapy, in order for them to regain strength and mobility. And during the acute phase, they will have some limitation into their physical activities during the initial recovery period. It's something that will actually going to be in place for the duration. Now, for the post-op nursing care, guys, what do you think about the post-op nursing care for a patient with a spinal fusion? Well, we're going to be worried about pain control. So your goal here is to manage that with the pain medications as prescribed. It could be the muscle relaxants, the non-steroidal agents, opioids. Same thing with the wound. We're going to definitely check this, the spot, incision site, for any signs of infection. We want to make sure if there is an order to apply sterile dressing into the site, then we're going to definitely do that. And as far as the mobility of our patient, we need to assist our patient during the ambulation. And they should have gradual increase in their activity. And with the spinal fusion, there's going to be a huge chance that they will be using the back brace as well as prescribed. Okay, back brace as prescribed. Now, as far as the immediate post-op care, our patient will need to have the neurovascular checking as well, circulation, sensation, motor checking, all those things. And our patient will be educated as well regarding activity limitations. That's huge. Make sure that they use proper body mechanics, and also make sure that they are adhering to those rehabilitation exercises. Now, the goal here, the overall long-term care for this patient with a spinal fusion, is to make sure that they show up to the follow-up appointments in order to assess the fusion progress, to see if they have spinal alignment. And we want to make sure that they have, they are adhering to the modifications in their lifestyle, especially with the activity. Okay, now let's move forward to another surgical procedure, which is the micro-discectomy. So what is this? This is another minimally invasive type of procedure, another surgical procedure wherein there is a removal of the herniated disc or the fragment that is pressing into the nerve root. So let's take a look into this one. Micro-discectomy. All right, again, this is the removal of the herniated disc. It could be the fragment itself that is pressing into the nerve root. And this is going to be done through a using that surgical microscope under general anesthesia. And so this is a procedure that will also require creation of a small incision made on the back. And the surgeon here will be using that surgical microscope to view the affected disc. And then they're going to have to remove the herniated material as well. Now, the procedure or the indication here will be similar to the discectomy. The same reason that we're going to relieve the nerve root compression caused by the herniated disc. Now, the benefit for having the micro-discectomy is that this is less invasive than the traditional discectomy. There will be lesser pain, they say. And there's also an expected faster recovery for the patient. And the patient will have minimal muscle damage and less scarring as well. Now, since this is a surgical procedure, there's also risk of having infection. There's also a risk for bleeding, nerve damage. The patient here will recover quickly this time and less post-operative pain compared to the traditional discectomy. And most of these patients can return to their normal activities within weeks, about 2 to 3 weeks after the surgical procedure. Now, if you're going to ask about the post-op nursing care, again, our goal during that phase would be to control the pain, We're also going to deal with the wound care, make sure that we are watching the site for signs of infection. If we are going to worry about their mobility, we need to assist them when they're ambulating. Definitely this is encouraged during the acute phase or post-op phase to prevent the complications like DVT. Another thing is we're going to have to do the neurovascular monitoring as well, the CSM, to make sure that we are capturing those impairment. Maybe there are some complications that might arise, reduction in their sensation, reduction in their motor function or weakness, and definitely include that in the immediate post-op care. Now, we also have the percutaneous discectomy, and this is going to be a minimally invasive procedure that is going to remove a small fragment right here. So take a look into the area. Okay, so again, this is going to remove part of a herniated disc through a very small needle-like incision, so a tinier incision. And so this is going to involve the insertion of a needle under the microscope or fluoroscopic rather imaging, and this is going to really specify the insertion. It will be much more targeted into that area directly. And so the herniated disc here will be removed using the instrument. And again, this is indicated mostly to a smaller fragmentation or herniation of the disc. And it's not going to be indicated into a larger form of injury. Now, the same with the other surgical procedures, there's also risk involved. There could be an incomplete removal of the disc material, or maybe there's some recurrence of the manifestations, or maybe an injury into the surrounding structures as well, and also infection. So those are the possible risks involved. Now, the same thing with the other surgical procedures. Our goal here is to control the patient's pain, make sure that they are assessed and monitored on their pain levels post-op. Same thing, we're going to have to monitor for any signs of infection, their mobility as well. We need to encourage them doing light activity and also promoting ambulation as tolerated. So light activity will be very important for all these surgical procedures. Light activity, ambulation, and avoiding strenuous activities. Heavy lifting, no. Avoid strenuous activities. Bending at the waist area or hip area, no. We're also going to have to do the neurovascular assessment. Don't forget about the CSM, circulation, sensory, and motor function as well. Now let's have another surgical procedure here, which is the Hemilaminectomy. So what is this Hemilaminectomy? This is going to involve the removal of only one side of the lamina, which is the bony part of the vertebra, in order to relieve the pressure. Okay, so the patient here will also have an incision onto the affected side of the lamina, and this is much more, or this is going to be less invasive compared to the full laminectomy. Okay, so take a look here into the removal of the lamina. It could be a partial removal. Now, the patient here will definitely have some relief of pain because of the removal of that compressing structure. Okay, it will reduce the impact on the spinal stability as well compared to the full laminectomy. And even though with this type of procedure, it also will involve some risk, they will have probably gonna have some complications, maybe incomplete decompression, or maybe they will also have potential for the recurrence of the symptoms. Now, if you are going to have to ask about the recovery here, It's quite similar to the laminectomy. It will involve the physical therapy as well. It will also involve gradual return to their physical activity. And as a patient is going to be in the post-op phase, we need to control their pain again. We need to check into their wound site, making sure that we are looking into signs of infection. We're going to have to assist into their mobility, gradual activity as well. And we're going to have to check into the neurovascular assessments as well, the CSM. So that's going to be part as well. Now, lastly, this is the known treatment, which is what we call as the chemonucleolysis. So this is not a surgical procedure. This is rather a procedure that can involve injection of an enzyme. Chemonucleolysis. Enzyme injection. So this is going to be done in a very sterile environment wherein the enzyme is going to be injected into the disc in order to dissolve the herniated nucleus pulposus. Remember about that gel-like structure? So this is going to dissolve the herniated gel-like structure into the disc. Now, what is this enzyme basically that is going to be given into the patient's disc? Well, this is an enzyme that will reduce the pressure onto the nerve roots. Reduces pressure in the nerve roots. So it's not going to be as invasive compared to those surgical procedures. And it has the same goal. It will break down the material. It will reduce the pressure into the nerve root caused by the herniated pulposus nucleus. Okay. Now, if you're going to ask, what is that enzyme? What is that specifically? This is a chymopapane. All right. So this is what they call as a product, a papaya enzyme. This is going to really help out in relieving the pressure by dissolving that herniated disc. And the patient will have much shorter recovery time compared to the surgical procedure. But here, guys, please take note that this is going to involve the injection of that enzyme. The patient might be allergic to that substance. And so hypersensitivity is something that we're going to need to follow through. We need to check on our patient if they might have some partial or maybe incomplete resolution of the symptoms, or maybe there might be some degeneration or recurrence in the herniation as well, okay? Or could potentially affect into the other levels of the vertebra. Now, what are we going to do here, especially when we are taking care of this patient post-procedure? What are we going to do after the chemonucleolysis? Nucleolysis, rather, post-procedure nursing action. Well, part of the care will be to control their pain. That's number one. We should be aware that pain may vary as the enzyme might work to dissolve the disc material. So there will be that pain that will be expected. Pain control, and also keeping an eye into the insertion site, injection site assessment. Okay. Now, again, this is to monitor for signs of infection, redness, swelling around the injection site. Make sure that you do that. Now, as far as the activity, what do you think would be the allowed activity for this patient? Well, the patient is going to do very light activities this time. They're not going to be allowed to do heavy lifting. So part of that would be post-procedure, no heavy lifting. And also make sure that they are doing the gradual return to the normal activities. And the same thing, we are going to have to check for the neurovascular assessment as well, circulation, sensation, and motor function checking. All right, guys, let's talk about the nursing care. Hello, Lydia. Sure. Actually, the videos will remain in the YouTube channel. These are not supposed to be removed. Those are free sessions that you can access. All right. Now, guys, let's talk about the overall nursing care here. I'm just going to mention about the general nursing care for the patient having the herniated intervertebral disc. So the number one goal for our nursing care here is to basically minimize the pain. That is first and foremost our nursing action. Minimize the pain. We're going to have to administer those prescribed medications, NSAIDs, opioids, non-steroidal agents, or could be the steroid-based medications, right? To reduce the inflammation. It will reduce those signs and symptoms. Now, also, guys, make sure that you are looking into the different side effects of the drugs, especially if there is involvement of, or if we are administering them those non-steroidal anti-inflammatory agents orally, or it could be the oral steroid drugs. These are known to cause gastrointestinal discomfort, ulcers. So make sure that you are careful in assessing your patient as well if they are developing these manifestations. And of course, don't forget about the actions. Make sure that you are administering these medications with food or snack in order to prevent peptic ulcer disease or erosion into the gastric mucosa. Okay. Another thing that we're going to need to do here would be to maintain mobility. This is important. Our patient should maintain some form of regular activity within their pain limits. We're not going to cause aggravation of their pain during the acute period. So, as I have said earlier, bed rest is encouraged during the first 2 days whenever the patient has that herniation. Okay, that is going to be the primary nursing intervention as far as during the acute phase. Maintaining mobility, but while they are in bed rest, they are still allowed to do some form of activity. Okay, now I'm talking about range of motion exercises here while they are in bed. And make sure that if the herniation involves the cervical area, well, if they have that prescription to wear the cervical collar, then make sure that this is placed properly fit, and also make sure that this is applied to the site with the correct application of the straps in order to maintain traction. Now, also take note about the skin care, especially inspecting the skin under the stabilization device or maybe the brace. We'll have to take a look into the skin integrity, look for redness, signs of pressure ulcers. Another would be to carefully turn our patients every 2 hours, lug rolling them, make sure that they are turned as a unit. Now, what else? We're going to have to prepare them for surgery, of course. If there is a severe involvement, severe compression of the nerve root leading into the radiculopathies, cervical or lumbar radiculopathies, then definitely we're going to have to prepare them for that procedure. We're going to have to inform them what the intent is, reinforce the education that was given by the medical provider. We make sure that there is that order. Make sure that the consent matches to the surgical order. Okay. Another thing is we're going to have to talk to the patient regarding the preparation, giving them some education about the incision that will be created if they need to undergo those individual surgical procedure, and make sure that they are taught as well how to do the pre-op and the post-op exercises, especially when they are going to be placed in bed mostly. All right. Now, please take note, guys, that we're also going to check and prevent those post-op complications. This is huge. Most of the questions here will be geared more onto the post-op care. So take note about frequent monitoring of their vital signs, taking note into the neurovascular check, vital signs, neurovascular assessments, circulation, sensation, motor. What else? Wound care. That is also another thing that we need to keep an eye on. Looking into the skin color, if there is redness, swelling, signs of drainage, pain into the surgical site. We want to make sure that we are reporting these signs of infection to the medical provider. If there is a need for drainage appliances, maybe tubing, maybe with the use of JP drains, Jackson Pratt drains, we will make sure that the tubing will be frequently checked for patency and make sure that there is vacuum. Remember about that proper application of that vacuum. We want to make sure that this is deflated after we had emptied the JP drain. Now, part of the care here is to also check on the patient's pain level. That's primary. Make sure that they are getting the adequate pain control so that they can also do those deep breathing, coughing exercises. Now, if they need to wear that cervical collar as ordered, if it's affecting the cervical region, then make sure that they have it on as well, properly fit. And as far as the movement, we're going to have to log roll them as well as a 1 unit. All right. Now, during the post-op phase, possibly early post-op phase, their gag reflex probably will not be there. So hydration is really important. IV fluids will be given up until their gag reflex or bowel sounds are present. So hydration with the IV fluids will be important during the immediate post-operative phase. We're also going to check into the patient's, what do you call this? Check for hoarseness, especially if our patient has undergone the cervical type of procedure. If they are doing the laminectomy or any of those surgical procedures in the cervical region, then we are going to monitor the patient for any hoarseness, which is signifying that they might have an injury into the laryngeal nerve. Okay, so please take note about that. Check for the sound of our patient, the hoarseness when they're starting to talk after they wake up. If there is hoarseness, you're going to call the medical provider about that. That's a complication. It could be the injury into the laryngeal nerve, and it can potentially affect their cough reflex as well. All right. Now, as far as the activity ambulation, this is going to be gradual as well. Most of the time, our patient will be assisted by, or let's say, for example, the physical therapy will be involved in this treatment. So they will be asked to evaluate first about the patient's status before we're going to have to ambulate them. So this will be a gradual activity for them. We're going to have to sit them first on the side of the bed and then make sure they are able to tolerate that activity. And then finally, maybe some standing, maybe with the use of their arms, maybe walking into the nearby chair. These are things that can be done gradually by the physical therapist. And again, as nurses, we are going to follow through with those physical activities, not do those things that is not recommended to prevent injuries. Okay? Again, do not go beyond what is recommended by the physical therapy. If they have this recommendation that they should not be doing this certain activity, then do not overdo. All right? Now, let's tackle here our first question of the day. I hope that you had learned something into that lecture. Let's have this first question. A patient with ruptured intervertebral disc at the L4, L5 level stands with a flattened back, leaning slightly forward, and to the side of the injury. The nurse interprets this as which of the following? Is this A, changes in motor function, B, deformity in posture, C, reflex alterations, D, changes in sensory perception? Let me reread the question. A patient with a ruptured intervertebral disc at the L4, L5 level stands with a flattened back, leaning slightly forward and to the side of the injury. The nurse interprets this as which of the following? Is it A, changes in motor function, deformity in posture, C, reflex alterations, or D, changes in sensory perception? Okay. While you are selecting the correct answer, I'm going to start having the rationale here. Hello, princess. Let me have letter D, changes in sensory perception. Take note, guys, about the scenario. The patient stands with a flattened back, leaning slightly forward to the side of the injury. And this case is in a patient with L4, L5 herniation or rupture of that disc. I'm seeing Anita answering letter B, deformity in posture. Let me try removing letter D first. Changes in sensory perception. Guys, this is incorrect if you answered letter D. The reason for that is because those sensory changes like tingling, numbness, these are only expected along the distribution of the affected nerve, but they are not indicated by the described posture in the scenario. Again, those sensory changes that the patient is experiencing, possibly tingling, numbness, are only expected in the distribution of the affected nerve, but are not going to be indicated by this posture in this patient. So what about letter C? Reflex alterations. What do you mean by that? Reflex alterations. This simply means that those changes would manifest, or the patient will manifest a diminished, or let's say they will have absent reflexes at the level of the disc herniation. Again, the scenario that we have does not reflect those absent or alterations in the reflexes. It did not mention anything about impairment in the reflexes. So we are going to remove that as well. What about letter B? Deformity in posture. What is this? Well, as you have seen in the scenario, there is leaning slightly forward to the left side of the injury. This is what we have in letter B, deformity in the posture. Okay, as described, there is leaning forward, or slightly leaning forward to the side of the injury. This is a common reaction, especially when the patient is in pain. They could be in moderate or severe pain, and they will tend to kind of lean towards that mechanical imbalance in order to attempt to alleviate the pressure. And so the patient will basically kind of lean toward that side that is unaffected, okay, in order to relieve pressure into that side that has the compression. So that is the correct answer here. What about letter A? Changes in motor function. Do we have any report that they are having motor changes? Apparently, no. We don't see any information about changes in motor. Nothing. Yeah. However, if the patient might have those motor changes, then possibly they could complain about muscle weakness. That's one. Or maybe they will have reduced muscle tone. That is another assessment finding whenever there is involvement in the motor function. Or could be the pronounced muscle weakness. Okay, so those are things that will reflect changes in motor function. But then again, our patient is only manifesting the slight movement to that side of the injury. Okay. Now let's have number 2 question. Which position is most comfortable for a patient with a ruptured disc at L5, S1 on the right side? Which position is most comfortable for a patient with a ruptured disc at lumbar 5 to sacral 1 levels onto the right side? Is it lying face down? Is it B, lying on the back with legs bent? Is it going to be sitting upright? Or is it D, lying on the right side? So we're talking about a patient with a ruptured disc at L5 to S1 levels onto the right side. They're having the pain into these levels. So what do you think would be the best position? Take your pick. All right, while you do your picking of the answer, let me have letter A. What is in letter A? Lying face down. Lying face down. What do you think about this? Well, when you're going to put them on their face, this can hyperextend the spine. Hyperextension is going to happen in their spine if they are going to do the face down or prone position. This is going to be hyperextension rather. Okay, hyperextension. What did I just say? Hyperextension. If the patient is allowed to do this, then it can also increase the pressure on the herniated disc. It will aggravate the pain. It can compress the affected nerve root. Okay, can aggravate the pain. Let's have letter B, lying on the back with legs bent. Will this help out? This is the position that is actually desired. It will reduce the pressure on the spinal nerve by allowing the disc to retract slightly, and this can also alleviate the pain. Having the patient flex their legs while they are in their supine position, this can open the spaces between the vertebra. This can relieve the pressure onto the affected nerve. Okay, so again, our lying on the back with the legs bent, this can cause the vertebra spaces or the vertebral spaces to open up. Opens the vertebral spaces. And if this is going to open up those spaces, of course, there will be a relief of the pressure onto the affected nerve. That's simple. If we're going to put the patient on a sitting position, well, we know that they have a ruptured L5-S1, right? This can cause more pressure into the injury site. It can worsen nerve compression if there's no proper support. Again, sitting upright without proper support can be detrimental into our patient. It can worsen the nerve compression. Can worsen the compression. And also, of course, with a pain that is going to be intense at this time. Now, let's take a look into lying onto the right side, letter D. Lying into the right side. Remember that the injury is basically onto the left, into the right side, affecting the L5-S1. So if you're going to put them into the right side, what do you think? This can exacerbate the pain all the more. It will lead to some more compression into the affected nerve root. More compression. In the injured nerve root. So let's go back to our answer, which is letter B. The best position for this patient that could be promoting more comfort. Okay, which position? The question basically is asking which position is most comfortable for this patient with a ruptured disc. So of course, if it is towards the right side, the goal here is to prevent more compression. And this is why letter B is going to be beneficial. It will open up those vertebral spaces. It will reduce the compression. And we're not just going to let this patient lay on the same position the whole time, right? We need to reposition. So if this is affecting into the right side, we can reposition them into their back with the legs bent. And also we can reposition them into the left side as a unit. Again, that would be your course of action here when you are repositioning into the patient, but not placing the patient into the right side. So it will be back with the legs flexed. You can also reposition the patient onto the left side. All right. And avoiding placing them in an upright position without support. Again, the caveat here, sitting upright without support can aggravate the patient's pain. All right, let's have number 3. A patient with numbness from the back of the left buttock to the top of the foot and big toe is scheduled for a laminectomy. The consent form states left lumbar laminectomy at L3, L4. What should the nurse do next? Is it A, ask the patient to sign the consent form? Is it B, contact the surgeon? C, alter the consent form? Excuse me. Or D, review the patient's medical history? What is your answer here? A patient with numbness from the back of the left buttock to the top of the foot and big toe is scheduled for a laminectomy. The consent form states left lumbar laminectomy at L3, L4. What should you do next? Okay, this is quite a difficult question. No kidding. It is a difficult question. You really need to identify the different levels and also the manifestations here. So let me have letter D. I'll eliminate letter D. What is in letter D this time? Review the patient's medical history. Take note, guys, about the consent. It's stating left lumbar laminectomy at L3, L4. But the patient is manifesting numbness from the back of the left buttock to the top of the foot. Remember, these are signs of radiculopathy, right? Numbness. Numbness from the back of the left buttock to the top of the left foot, big toe. But the order or the consent form stated left lumbar laminectomy L4. But first, let me eliminate letter D first. Review the patient's medical history. What about this option? What do you think about this? Yeah, we know that we should be reviewing the medical history, right? It will give us better information before the patient will be sent to the surgical suite. But here, The consent actually has a discrepancy, and there is a reason for that. Why there is a discrepancy? We know that the patient has the numbness already, but the consent is stating L3, L4. It's not matching, guys. There is a discrepancy that will be clarified by the nurse to the medical provider. And so the goal of this question is to make sure you identify what to do next, right? We are going to contact the surgeon because the manifestations that the patient is displaying is actually signifying radiculopathy in levels L4 and L5. Okay. The consent is stating L3, L4. They would not be manifesting this kind of manifestations if the injury or if the manifestations are within the L3 and L4. But here we have our patient complaining of the numbness. This is specific to that layers or level L4 and L5. So this time, guys, before we're going to allow the patient to sign, because this is a discrepancy in the order, we need to contact to make sure that this is corrected before we're going to allow them to sign the consent. Okay? This is specific to the L4, L5. So we need to contact the surgeon first. If you're going to allow them to sign the consent, or I'm talking about the patient, you're not being a patient advocate this time, as we know that the manifestations are indicative of L4, L5, radiculopathy. It's not L3, L4. So do not do that. The same thing with letter C. The consent form is a legal document. You should not be altering the consent on your own. Yeah. Do not do alteration, especially this was already indicated. And most of the time, the consent form is a mirror to the medical provider's order entry. If they had done it in the chart, that this is basically the site of the what do you call this? If they're going to perform this such surgical procedure, it will actually mirror the medical provider's order in the chart. And so make sure that everything is going to be fixed by calling the doctor first. You're not going to do this as well. Make sure those discrepancies are fixed before we proceed in having the patient sign the consent. Okay, please take note of that. Let's have number 4. After a laminectomy, the patient states, the doctor said, I can do anything I want. Which of the following activities indicates the need for further instruction? Is it drying dishes? Is it B, sitting outside on firm cushions? C, making the bed by walking from side to side? Or is it D, sweeping the front porch? Your patient stated that his doctor said something that he can do anything he can. And so which of those activities would indicate that he needs teaching? Is it drying dishes? Is it sitting outside on firm cushions? Or making the bed by walking from side to side? Or is it sweeping on the front porch? Guys, the strategy in answering this question is to identify those activities that will involve twisting. You're going to identify those activities that will involve bending. That can potentially jeopardize their healing process. Okay? So which of these activities can really aggravate the surgical site? Okay, let's have letter A, drying the dishes. Drying the dishes, which is basically not require any bending or twisting. You're just going to allow them to use the dry towels, right? Wiping those dishes or maybe utensils. It is a procedure, or it's a step or an action that can be safely done after they have the laminectomy procedure. So we are eliminating this one. What about letter B, sitting outside on firm cushions? We want to make sure that our patient's bottom, or we want to make sure that they are actually maintaining good posture and make sure that they are doing those activity correctly. So sitting outside on firm cushion. This will actually support their back. Firm cushion, not soft. We're talking about firm cushion here. This is going to support their spine, maintaining that good posture. So we are going to eliminate that because this is not going to aggravate the surgical site. What about letter C? Making the bed by walking from side to side. Making the bed. What about this? Making the bed can actually avoid twisting and bending with the applicable word here, from side to side. This is going to prevent the twisting and bending. So this is going to make the activity safer. And yeah, it is safer for this patient to perform this task at home. So we are going to eliminate that. So we are now going to have letter D, which is sweeping the front porch. What is involved in sweeping? When you are doing this, or when you're allowing the patient to do the sweeping, it can involve the twisting motions, which is going to be avoided, supposedly, right? After they have the laminectomy, they should not be bending. They should not be twisting as well, in order to prevent undue stress into the surgical site. And this can complicate things. It can lead to muscle spasms and potential re-injury to the site. Involves twisting. All right. So this is the activity that should be addressed by the nurse during this conversation. We have letter D this time. Again, guys, look for those activities that can promote bending and twisting post laminectomy. Now let's have number 5. The nurse is creating a discharge teaching plan for a patient returning to work 6 weeks after a lumbar laminectomy, levels L4, L5. Which action should the nurse avoid, or should the patient avoid rather? Is it A, using a step stool for 1 foot while standing for long periods? Is it B, sleeping on the back with support under the knees? Or is it C, keeping a healthy weight for height? Or is it D, sitting whenever possible? So the question here is to identify that activity that the patient should avoid after they had the lumbar laminectomy for levels L4 and L5. What do you think about this? Okay. What action, or which action should the patient avoid after returning to work 6 weeks post laminectomy to the L4 and L5? Alrighty, let's have letter C this time. Or let's have letter A this time. Using a step stool for 1 foot while standing for long periods. Is this going to help the patient, or is this going to cause injury to the patient? This is the statement right here. Using a step stool for 1 foot while standing for long periods. So it could be maybe At a later time, the patient will have to, again, switch sides. So the other foot this time will be placed on the step stool to kind of shift the weight, all right? Okay, so let's have letter A. Using a step stool for one foot while standing for long periods. Will this aggravate the injury? Well, this action is actually a good practice. This will help maintain the proper spinal alignment, and it will reduce the stress on the lower back. This is a good intervention. This is going to reduce the stress on the lower back. Okay. This is incorrect. This is a good option. I mean, this is a good practice. So this is not what we are looking for in this scenario. What about letter B? Sleeping on the back with support under the knees. Sleeping on the back with support under the knees. Remember about what I said earlier regarding that opening of the intervertebral disc? It can decrease the pressure. It can also maintain the alignment of the spine. It can decrease the pressure onto the lower back. So this is basically a good intervention as well. Support under the knees. It will reduce the pressure on the back, and it can also decrease pressure into the surgical site. All right, let's have letter C. Keeping a healthy weight for height. Yeah, of course. This is quite obvious. When your patient is prescribed to maintain that appropriate weight, it will reduce the strain onto the back, and it will also support the overall spinal health and its recovery. So we don't have any other answer but letter D. Sitting whenever possible. We are looking for that action that the patient should avoid doing. Sitting, yeah. By gravity, guys, sitting can increase the pressure into the lower back, and this is something that you should teach the patient to avoid, especially after they have the laminectomy. Okay? If they have to sit, for example, maybe they need to get their meal for breakfast, dinner, or lunch, they should use chairs that can support their proper posture, okay? And make sure that when they are sitting, okay, so just describing here right now, they should have this kind of chair that will enable them to support their posture. Make sure that their knees are going to be higher than the hips, all right? During the meal times, they are allowed, they're not supposed to be prevented from sitting, but not sitting whenever possible. That's totally different. They can be allowed to sit for meal time so they can eat, right? But again, the position of their knees should be higher than the hips. Should be higher than the hips. Okay, so this will reduce also undue pressure into the area. Okay, yeah, try it at home. Even though if you don't have any injury or laminectomy, try it. Feel for the differences in the amount of pressure to the back if you're just gonna let your knees in the same alignment with your hip or at the same level. Compare it to when you're actually lifting or when you are putting like a step stool. for this patient to rest their feet. Yeah, take note of that difference in the pressure point into the back. There's a huge difference. Again, guys, the role of, or the primary goal of this question is basically to identify those positions that can cause excessive pressure into the surgical site, or that can cause strain into the spine post laminectomy. All right. So make sure that there should be lifestyle modification. Make sure that the patient is taught to keep their knees elevated after the laminectomy. Make sure that they're using a step stool to elevate that. Or when they are standing for a prolonged period, they can also use that step stool, kind of alternating. Maybe if they need to stand for quite a long period, then they're going to have to switch sides. And again, the reason for that is to reduce the strain into the surgical site. All right. And when they are on their bed, they need to have that support under their knees. If they're on their back, they can be turned onto the side as well. But here, when the patient is on their back, make sure that their knees are supported. All right. So let's have number 6. A male patient underwent a spinal fusion yesterday. Which of the following assessment indicates a potential complication? Is it A, turning the head and neck to the side? Is it B, clear yellowish fluid on the dressing? Or C, standing to urinate? Or D, a non-productive cough? A male patient underwent a spinal fusion yesterday. Which of the following assessments indicates a potential complication? Is it A, is it B, or C, or D? All right, while waiting for your answers, I'll start rationalizing this time. Let me have letter A. What is in letter A? Turning the head and neck to the side. Well, this is acceptable and should not cause any discomfort to this patient, right? Spinal fusion. They can turn their head and neck to the side. It's generally acceptable. It doesn't indicate a complication. What about letter D? A non-productive cough. Is this a complication? Well, if the patient is trying to do the coughing to clear the lungs, non-productive cough is basically a normal post-op response. But if they will have frequent, that's another story. If the statement is frequent non-productive or productive cough, that could indicate something else. But if it's only stating a non-productive cough, this is a normal reflex to clear the lungs. It's a normal post-op response. So we are not taking, or we're not going to pick this answer. What about standing to urinate? Would that be a potential complication? No. Standing to urinate is a normal activity for a male patient, and it doesn't really indicate a complication. So for a patient having that clear yellowish fluid onto the dressing, this is a significant assessment finding. Yeah. If there is now drainage of that yellowish fluid, this is the CSF. Okay. This is a sign of CSF leakage. And you should be testing this for glucose. Test for glucose. Now, what is the risk if there is going to be leakage of the cerebrospinal fluid into the dressing? Remember that we are talking about spinal fusion. That involves the creation of that incision. There will be placement of the implant, that artificial gel-like disc, and there's also placement of the rods and also the screw. Yeah, the presence of the CSF leakage is going to be a complication which will put the patient into infection. High risk in developing infection. It's a big deal. This is a life-threatening manifestation. The patient is not going to I got distracted right here. The patient is prone to developing the infection this time. Letter B. Okay. The patient is high risk of developing the infection because of that leakage. All right. Now take a look into the others. Are these going to be needing action right away? Like I've said earlier, letter A, turning the head and neck to the side. This is an expected finding. Standing to urinate as well. A non-productive cough. Those are usual activities that you should not be alarmed of. But if in case you will be seeing this leakage, this is a means of the entry of those opportunistic infections into the incision site. So this is something that you should test right away for glucose, and of course notifying the medical provider if you have done your testing. All right, make sure you do that. This will hasten the treatment if you're going to notify them right away. Now let's have number 7 rather. After teaching a patient about wearing a back brace post-spinal fusion, which patient statement indicates correct understanding? Again, after teaching a patient about wearing a back brace post-spinal fusion, which patient statement indicates correct understanding? A, I will put on lotion before wearing the brace. Is it B, I will pad the area around my hip bones? Or C, I can use baby powder to absorb sweat under the brace? Or is it D, I should wear a thin cotton shirt under the brace? After teaching a patient about wearing a back brace post-spinal fusion, which patient statement indicates correct understanding? So there is a prescription to wear the back brace post-surgery. So which of those? You're answering letter D, which is I should wear a thin cotton shirt under the brace. Yes, that is the correct answer for those patients that are actually going to wear those braces, TLSO or whatever appliance that is. The brace should not get into direct contact with the skin. There should be a barrier, and that should be a thin cotton shirt under the brace. This will prevent the constant rubbing against the patient's skin and also the brace itself. It will prevent those from happening. And also the shirt itself can absorb moisture. It can absorb moisture. It prevents constant rubbing. All right, so that's the reason why they should be wearing that cotton shirt. There should be a layer that will protect the skin from the brace. So if you answered letter C, which is application of powder to absorb sweat under the brace, if you answered letter C instead, whenever the patient will become sweaty, what do you think can happen if they will become sweaty, if there's moisture? The talcum powder can actually cause skin irritation, as this can lead to clumping of the powder whenever they're going to be sweaty. Okay, it can cause clumping. So this will further cause skin irritation. What about letter B? I will pad the area around my hip bones. Well, the statement is stating something about padding, but it's not very specific, padding the area around the hip bones. What do you think about that one? If there is an additional padding on top of the shirt, that thin shirt, it will add more pressure points. If it becomes wrinkled, then there is going to be a higher risk of skin irritation. High risk for irritation because of the additional padding. If you're going to put lotion before wearing the brace, well, lotion, has this been advised? No. The lotion can actually increase the moisture into the skin and will lead to the breakdown under the brace as well. So this will be a good environment for the microbial agents. Again, lotion application under the brace can lead to excessive moisture. And with that, skin breakdown can follow. Again, if there's a skin breakdown, the patient will have a much more conducive growth for the bacteria with that presence of lotion. So we are marking letter A, B, letter C as wrong options. Our correct answer here will be letter D. All right, that's how we manage the patient's brace. Let's have number 8. But before we go to do that, again, I am inviting everyone to enroll into our NCLEX course via Stancoast, NCLEXcoaching.com, and also take a look into our description box below. We have the link there. And for those who are looking for the promo code, I spoke with the boss yesterday. The price of the course is actually discounted at 75%, and so this time there's no promo code available yet. Okay, so for those who are interested to sign up, please do so. Now let's proceed with number 8. The nurse develops a teaching plan for a client scheduled for a spinal fusion. Which of the following should the nurse include? Is it A, the client typically experiences more pain at the donor site than at the fusion site? B, the surgeon will apply a simple gauze dressing to the donor site? Or is it C, neurovascular checks are unnecessary if the fibula is the donor site? And letter D, the client's level of activity restriction is determined by the amount of pain. So you are the nurse developing a teaching plan for a client scheduled for spinal fusion. Remember about that procedure, that there is going to be an implantation of that artificial gel structure, and also there's going to be application of the screws and the rod to support the vertebra. So what you should do, which of the following should the nurse include in the teaching? Okay. Let's have letter D this time. The client's level of activity restriction is determined by the amount of pain. Take note of the statement here. Level of activity restriction is determined by the amount of pain. So basically you're saying that if the pain is severe, then you are going to restrict the activity. Or let's say if the pain is mild, then the activity is less restricted. Is that how we are going to do the education? I guess not, right? It is not going to be determined by the amount of pain that they are encountering. No. Now let's take a look into this one. The activity level is going to be prescribed by the surgeon solely. Okay, activity restriction is going to be rigid this time. It is going to be prescribed by the surgeon. It's not according to the amount of pain. Okay. That would be kind of difficult, guys. If we are going to limit their activity according to the pain, that would be so difficult to manage. That is unsafe as well, as far as making sure there is no re-injury to the site, especially that there is fusion of those vertebra. That would be unsafe to practice or to teach our patient, especially during this phase. They would probably think, hey, I can do anything that I want as long as the pain is not severe. No, that would cause more risk of complication if they are allowed to do so. If they are having lesser pain, that would create misunderstanding as far as post-operative care. The rehabilitation here would be somewhat ineffective. So we are eliminating that one. What about letter C? Neurovascular checks are unnecessary if the fibula is the donor site. Unnecessary? They're critical. We know that every surgical procedures that we had encountered earlier, remember, I've always emphasized about the neurovascular checking, post-operatively checking into the circulation, sensation, the motor function of that particular leg, especially if the fibula is the donor site, right? And so again, this is going to be an incorrect statement. What about letter B? The surgeon will apply a simple gauze dressing to the donor site. The implantation site. The surgeon will apply a simple gauze dressing to the donor site, which is basically the area where they are harvesting the that organ. What do you think about that? Instead, that they're going to apply a gauze dressing into the from the donor site, or to the donor site rather. Simple gauze dressing is not correct. They should be applying a pressure dressing. Pressure dressing will be appropriate this time, not a simple gauze dressing. And the reason for that is to control venous bleeding and oozing. Okay, not a simple gauze dressing. So let's have letter A. What do you think about letter A? The client typically experiences more pain at the donor site than at the fusion site. What do you think about that statement? They will have more pain at the donor site. That is a true statement. The pain in the donor site, especially where they harvested that artificial or that implantation, the source of the implantation, this will be more painful compared to the fusion site, as there's going to be inflammation, there will be swelling, there could be oozing to the area where the subcutaneous tissue was removed. And this is a pain that will be pronounced during the first 24 to 48 hours. Pain is expected to elevate or increase during the first 24 hours to 48 hours post-op. Okay, so guys, the spinal fusion will also include or involve the harvesting of that tissue from the other area of the body. Okay, so this is going to be another alternative. They're going to get a tissue from the person's own body. It is going to be the subcutaneous area. And so when we are going to care about this patient in the post-op phase, the pain in the area where they get that tissue will be much more painful compared to the fusion site where they're going to put that tissue. All right. So this is a correct statement. Again, it's because of the increasing inflammation, the swelling, and also venous oozing where the tissue has been removed. And so we are going to deal the patient's pain around this time, around the clock. Make sure that they are getting the prescribed pain medications this time. All right, guys, the correct answer here is letter A. Let's have number 9. A client who has had a lumbar laminectomy with a spinal fusion is sitting in a chair. Which of the following is the correct position for the client? Lumbar laminectomy. Okay, I want you to pay attention here. Patient is post-lumbar laminectomy with spinal fusion, sitting on a chair. What would be the correct position for this client? Is it A, on the floor with the feet flat, B, on a low footstool, or letter C, in any comfortable position with legs uncrossed, or letter D, on a high footstool so the feet are level with the chair seat? So which of those are appropriate or is appropriate for this patient with laminectomy in the lumbar site? What do you think, guys? Let me try to eliminate. Let me have letter D this time. On a high footstool, so the feet are level with the chair seat. So if I'm going to have to create a diagram about that one, so that's a chair. And we are going to employ the use of a high footstool. Footstool that is high. Imagine that. Patient sitting. Their feet are planted right there. So what do you think will be the angle? The angle will be too high for this patient. It's not similar to what I depicted earlier, wherein there is just an elevation, right, with that footstool. That this is way too different. High footstool, so the feet are level with a chair seat. Okay, the feet of the patient will be in the same level of the chair where they are sitting. Well, what do you think about that? If there is excessive elevation of the feet, wherein it's already level to the chair, it can increase the pressure onto the incision. This increases pressure to the incision. And of course, can lead to more complication. It could lead to wound gaping as well. What about letter C? In any comfortable position with legs uncrossed. Let's take a look into that one. Any comfortable position, legs uncrossed. Well, if the patient is sitting in an incorrect position, even if they are comfortable, this can also increase the pressure onto the surgical site, and it will prevent the wound to heal as well. Again, even if they are comfortable, but if the position is incorrect, it can also increase the pressure to the surgical site. So the rationale will be similar to letter D. This is also incorrect. What about letter A this time? On the floor with the feet flat. What do you think about that one? On the floor. We are going to definitely put the patient's, we're going to have to put the patient's feet flat on the floor. This is going to help avoid the strain on the incision site. It will also reduce the pressure onto the suture line, and it will minimize the risk of inflammation, and it will reduce the re-rupture of the disc as well. Okay, so we are talking about post-lumbar laminectomy. We are going to ensure that their feet are planted on the floor flat. Okay, the reason for this is to prevent the strain onto the incision site. We're going to have to reduce the pressure onto the suture line. It will minimize the inflammation and re-rupture. So if we are going to use the low footstool, this can also increase the pressure onto the suture line, which may also lead to the inflammation and the complications. Okay, so the correct answer here is letter A. Let me just take a look real quick into the previous question. Let me see where that was. So this was a situation in number 5. This is totally a different situation wherein the patient is returning to the medical provider's clinic or something like that. This is the nurse is creating a discharge teaching plan for a patient returning to work 6 weeks after lumbar laminectomy. So this is totally different, guys. The patient has already been healing this time. And so the application of that footstool is going to be appropriate since it has already allowed the healing process of the surgical site. But then again, this scenario was asking about which action should the patient avoid. Okay, you remember about the scenario earlier that we should teach the patient to avoid sitting whenever possible, because when they do that, this can increase the pressure on the lower back. Okay, this is totally a different scenario. The reason for this test question is to avoid those activities that can increase the pressure onto the lower back. It's not about the incision or the wound that is still trying to heal. The patient is already healing this time. This is 6 weeks after. So if we were going to compare it to the recent scenario, this is on a patient who just had a lumbar laminectomy. This is a fresh post-op patient. Okay? And so as far as the sitting position of this patient, when they're allowed to do so, let's say they're taking a meal, then make sure that they are sitting just as usual. Their feet should be planted on the floor flat. And again, the reason for that is to reduce the tension into the surgical site, because this is a fresh post-op patient. So totally different scenario. So please don't carry what you had in the previous situation. Let's have number 10. The nurse creates a care plan for a client who is in the early post-op period following a lumbar laminectomy. Which of the following activities should be avoided? Is it A, assisting with daily hygiene activities? Is it B, lying flat in bed? C, walking in the hall? Or D, sitting in a chair for extended periods in her room? Okay. Your patient is in the early post-op period following a lumbar laminectomy, and you're the nurse creating that care plan. So which of the following activities that the patient should avoid doing? Is it A, is it B, is it C, or D? Should be avoided. What do you think about that? You are creating a care plan. You have a clue already from the previous, which is good, right? All right, the correct answer for this test question is letter D. This is the correct answer. Sitting in a chair for extended periods in her room, fresh post-op. Again, we are not going to recommend this, especially right after a lumbar laminectomy, because it can lead to increasing pressure into the nerve root and also the incision site. Can increase the pressure to the nerve root and incision site. So that's the rationale why we should prevent her from doing this prolonged sitting in her room. Okay, that is the correct rationale. Letter A, assisting with daily hygiene activities. Of course, that's part of the recovery, right? They should be able to be helped. We need to assist them with their daily hygiene because during the initial post-op period, the patient will definitely require some help in order to get them back into their normal functioning. And this will also help them out with the overall recovery. But then again, this should only be limited by the client's pain and also the weakness. So again, they should be assisted. But again, this is not going to be avoided this time. What about letter B? Lying flat in bed. Is this something that should be avoided? No. Lying flat in bed, it didn't say consistent or constant. It just said lying flat in bed. This is appropriate for the patient who had a lumbar laminectomy. This is appropriate. It is not going to put stress onto the spinal cord, or the spinal column rather, okay? So here, guys, what to avoid here? Avoid twisting, flexion. Those are the things that we should teach our patient. Avoid twisting and flexion. So putting them in a flat position in bed as needed, then this is not going to cause problem into our patients. So we are going to eliminate this one. What about walking in the hall? As part of the recovery of our patient post-laminectomy, we are going to encourage them walking. It will help promote their breathing, their circulation, the return of their peristalsis. This will be beneficial for our post-surgical patient, okay? It will also help them with their endurance and muscle strength without stressing into the surgical site, okay? So make sure you have that as well. Provided that we have the brace, right? Remember about the brace that will be applied as well. So walking into the hall would be beneficial. So our correct answer, which is something that the patient should avoid, is letter D. Again, as a recap to this question, I just want to emphasize again that we are looking for that test option that can cause unnecessary stress onto the surgical site. And we should emphasize those positions and activities that can promote healing, circulation, recovery, and to avoid those twisting and flexion body positions. Alrighty, let's have number 11. Which exercise should a client avoid after having a lumbar laminectomy? Which exercise should a client avoid after having a lumbar laminectomy? Is it A, bringing chest or bringing knees to the chest? Or is it B, tilting the hips? Or C, doing sit-ups? Or D, pelvic tilting exercises? What do you think? It's not saying immediate post-op. It's just saying post-lumbar laminectomy. Okay. What do you think, guys? Okay, keep looking to the answer. Let's have letter D this time. Pelvic tilting exercises. What is that all about? Pelvic tilting exercises. This type of exercise are actually, they are designed to enhance the core strength. They're going to improve the posture of the patient without placing stress onto the back. And this is going to make them safe, and this will be much more beneficial for the patient after the laminectomy. So actually, this is a good exercise. So this is not something that they should avoid. Pelvic tilting exercises is wrong. They're going to enhance core strength, and it will also promote posture. Core strength is enhanced, and they will also have an improvement in their posture with this. Now let's have letter B. Tilting the hips. What does that mean? Tilting the hips. The hip tilting actually would be beneficial as well. This is going to help strengthen the core muscles. It can support the spinal stability, and it is also a recommended exercise after a lumbar laminectomy. So this is wrong. Recommended instead. If you're going to answer letter A, bringing knees to the chest, it doesn't really mean that you're going to have to put the knees and the chest together. It's just the direction of the movement is actually knees to chest, not putting them together. That's totally different statement. Bringing knees to the chest is going to be beneficial as well. This can strengthen the back muscles. Strengthens back muscle. So I just don't want you to get confused here. This is not basically allowing them to put their knees towards their chest like in the maximum angle. No, this is basically allowing them to exercise while they are probably in bed. They kind of have to flex slightly the knees towards the chest, but not excessively to the point that it's actually there is hip flexion. No, excessive hip flexion should be avoided this time. So this is going to be acceptable exercise as well. If you had answered doing sit-ups, this is totally different from bringing the knees to the chest. The sit-ups will require more effort. This is going to cause more strain into the back, right? Wherein the patient's angle in the hip is so excessive. That is totally different, guys, compared to the bringing knees to the chest exercise. Again, this is something that can stress the surgical site and impede recovery. Stresses surgical site. So we don't have anything else but letter C. Again, letter A is going to strengthen the muscle. Letter B, tilting the hips, it is recommended. Tilting the hips basically is going to what? It will strengthen the core muscles. Core muscle strengthening. And when this is achieved, there is much better support. There will be spinal stability if they have better core muscle strength. All right. The same thing with letter D, pelvic tilting exercises. This can also promote the muscle core strength. All right. So what is really the significance about this test question? You are going to look for that activity that can place undue stress into the recovering surgical site. All right. So those hip flexion can actually pass the hip area that can re-injure the surgical site. Let's have number 12. A patient who had a spinal fusion for A herniated disc reports numbness and tingling in the right lower leg. What should the nurse do first? Is it A, inform the surgeon about the patient's complaint, or B, review the pre-op assessment data, or are you going to C, check vital signs for signs of bleeding, or D, position the patient on the left side to reduce right leg pressure? So your patient, after a spinal fusion, after they had a herniated disc, they're now reporting numbness, tingling in the right lower leg. So what would be your initial action this time? Their status post spinal fusion, but they're now reporting numbness, tingling in the right lower leg. Are you going to report to the surgeon right away after the patient had complained? What else? Anybody else who can answer this test question? Are you going to check the vital signs for signs of bleeding? Or are you going to position the patient? Or are you going to review the pre-op assessment data? Which of those options? So your patient is status post spinal fusion. Now they're reporting numbness and tingling. Okay. Calling the doctor is good, but that should be done if you had done your diligent assessment, which is basically reviewing the pre-op assessment data before they had the surgery, right? So this time, guys, before you're gonna make that step, before you make that phone call to the medical provider or the surgeon, you need to take a look also into the previous assessment results. Take a look if the patient had the same manifestations. Did they have numbness? Did they have the tingling in the leg? So that would be our first step, okay? The reason for that is to compare the current complaints of the patient, especially if these are neurological complaints. We have to be very careful before we make a phone call. Make sure that we have baseline information. Is it quite the same, or is this a new finding of our patient? So if this is a new finding, or let's say if there is worsening of the symptoms, then that's the time we're going to make the call. All right? You should promptly call if you have already done the review of the previous assessment data, and if these are worsening symptoms, or if these are new symptoms, then definitely you make that call. All right? But don't do the opposite sequence, okay? Let's have letter C. What do you think about check vitals for signs of bleeding? Do you think this would be something that can point out the numbness or the neurological manifestations? Guys, please take note that the numbness, tingling sensation in the right leg are not typical signs of hemorrhage, okay? We know that checking the vital signs are important. Before we make that phone call, we have to make sure that we have the set of vitals. Yes, this is important, but it does not address the specific neurological symptoms that we have described in the scenario. It doesn't really give us clues, or it will not give us a better idea regarding the changes. All right? But again, the numbness and tingling sensation are not closely related to hemorrhage. Not related to hemorrhage. Important to check vitals before calling. That's also important. Make sure that we have that data. But then again, with this question, is actually wanting us to do an assessment that is related to the numbness. And again, this is not, the vital signs is not closely related to that one, okay, with a hemorrhage. So we are removing that one. Let's have letter D. Position the patient on the left side to reduce the right leg pressure. Tingling in the right lower leg. So the statement here is position the patient onto the left side to reduce the right leg pressure. Do you think that this would relieve the patient's numbness or tingling? This is going to unlikely resolve that issue because this is related to nerve compression caused by nerve compression and this actually can delay the appropriate assessment and intervention if you're going to do this. If you're just going to position them onto the left side to reduce that pressure, it will not work. Remember that the compression is actually to the site of the surgery. It's not on the extremity alone, okay? So this will not be effective. So we are marking that as well. Again, letter A, informing the surgeon, will be done once we have collected first our pre-operative assessment data, reviewing rather. So make sure that you have that comparison. Hey doctor, our patient right now is having the numbness, they have the tingling sensation, and already reviewed the pre-op charting. Our assessment data did not have that kind of manifestation. So this is an emergency that should be dealt with accordingly. This is a normal assessment. So that's the time that you can make that phone call, but not going to take place letter B. All right, so make sure you do letter B first. Assessment. Review is part of the assessment. Review of records. That is part of the assessment. Okay. And the reason, again, this is to compare the current and the past assessment findings. Number 13, how should a nurse reposition a patient who has recently undergone a laminectomy and discectomy? How should a nurse reposition a patient who has recently undergone a laminectomy and discectomy? Is it A, instruct the patient to move the legs first before turning the rest of the body? Or is it B, have the patient turn by gripping the side rails and pulling over their shoulders? C, place a pillow between the legs and turn the entire body simultaneously. D, turn the head and shoulders first, followed by the hips, legs, and feet. So this is a scenario of a patient post-laminectomy and discectomy. So what would be the technique in repositioning this patient in bed? Will you instruct them letter A, or will you have them do letter B, or is it letter C or D? Okay, always observe that technique that can promote spinal alignment. This is what we are going to promote here. Prevent twisting, prevent flexion or bending to the hip area. We don't want that. We want to make sure that our patient maintains spinal alignment. Okay? Make sure you have that in your answer. So what would be that step that can maintain spinal alignment? This is huge, guys. That's why I'm trying to repeat all these about laminectomy. All right, I'm seeing now letter C's. That's good. Very good. That is the correct answer, guys. Place a pillow between the legs and turn the body or the entire body simultaneously. Lug roll. Don't forget about that concept. Whenever you have a patient that has laminectomy, discectomy, or any of those other surgical procedures that we had mentioned, and the same thing when they have that injury, lug rolling is something that you should stick to your mind. Okay? Place a pillow simultaneously. That's the clue right here. Lug rolling. Good morning, Puspa. Welcome. So, with that pillow placement between the legs and turning them simultaneously, it will maintain alignment. So let's have that. Spinal alignment is maintained. What else? Prevents twisting. And if we are preventing the twisting, it can also reduce the stress onto the surgical site. Reduces stress to the surgical site. Okay. Our goal here is to make sure that there is healing that is not disturbed by improper positioning, guys. Healing is our utmost priority this time, post-surgiry rather. If you had answered letter A, instruct the patient to move the legs first before turning the rest of the body. This is an act of twisting. This is going to cause misalignment and increase the risk of injury to the site. This is twisting. Right? What about letter B? Have the patient turn by gripping the side rails and pulling over the shoulders. He is attempting to move himself by grabbing the side rails over the shoulders. And what about the rest of the body? This is going to cause misalignment as well. Letter B causes misalignment. So we are supposed to eliminate that one as well. And then letter D, turning the head and shoulders first, followed by the hips. This is a good twist. Again, you're not promoting the alignment of the spine this time. Eliminate D, eliminate B, and letter A. So, lug rolling, guys, don't forget that concept. Let's have number 14. What should be included in the pre-op teaching for a patient scheduled for minimally invasive spine surgery? Is it A, the surgery will use an endoscope? B, intensive physical therapy is necessary after surgery? C, closed spine surgery carries higher risks? D, recovery time is longer compared to open spine surgery. Question is, what should be included in the pre-op teaching for a patient scheduled for minimally invasive spine surgery? Is it A, the surgery will use an endoscope? B, intensive physical therapy is necessary after surgery? C, closed spine surgery carries higher risk? Or D, recovery time is longer compared to open spine surgery? Let's eliminate options. Let me have letter D. Recovery time is longer. Do you think that recovery time is longer in a minimally invasive spine surgery? Minimally invasive. Remember what I said earlier? There will be less or there will be shorter recovery time that will be required for a patient whenever they have the simpler surgical procedures. Remember about that, right? If you're selecting letter D, time is longer. Recovery time is longer compared to open spine surgery. That is false. Because when we have the minimally invasive surgery, okay, this actually will use the endoscope, which is letter A. Very small instrument, which will allow the entry of the instrument into the surgical site, it will require small incision. Small incision with the use of an endoscope, very tiny instrument that can be accommodated by that small incision. With this, the risk is actually lower. There will be reduction of risk. The recovery time is reduced because of the small incision. So that is the correct answer, guys. Smaller incision can have lower risk. It will require small incision. Lower risk. Faster recovery. Or let's say shorter recovery time requirement. Okay. So this is wrong. Closed spine surgery carries higher risk. That is false, as I have mentioned. And B, intensive physical therapy is necessary after surgery. That is also false. Remember, guys, that when the patient has the minimally invasive type of procedure, they are going to require less physical therapy. Okay? They will require less of that. Less intense. All right? So let me add to that. Less intense PT. All right. All righty. So our correct answer here is letter A. It's a minimally invasive procedure. All right, let's have number 15. The nurse determines a client needs further education when the client who has a herniated lumbar disc makes which statement? Is it A, pelvic tilt exercises will help strengthen my back muscles? B, maintaining a healthy weight will reduce back strain? Or C, I should bend at the waist when lifting objects? Or D, increasing fiber and fluid intake is important? We are looking for that statement that will require further education. So which of those statements simply means that they do not understand the treatment? What do you think? All right, while you are selecting for the answers, or the answer rather, let me eliminate, I'm gonna have letter A this time. What is in letter A? Pelvic tilt exercises will help strengthen my back muscles. Yes, that is beneficial to strengthening the core muscles. It will also support the spinal health and also the healing. It is a recommended exercise. Remember what I said earlier about the pelvic tilt exercises? This is a recommended activity. Okay, we are going to eliminate that one. What about letter B? Maintaining a healthy weight will reduce back strain. Yeah. Remember about obesity can actually allow more strain into the spine. If we are going to maintain a healthy weight for this patient, or if they're able to do that, then of course that's a positive, right? So we are eliminating this as well. This is a recommended action. If you are answering letter C, I should bend at the waist when lifting objects. This is a red flag, especially bending at the waist plus the lifting of objects. We don't know really what the object is. Is that heavy? Is that light? It's kind of vague, but our red flag here is bending at the waist. What does that mean? Well, your patient should not bend at the waist level, okay? Instead, what they should be doing will be to bend at the knees, okay? Contraindicated. Hi, Joshua. Welcome to our review. This is highly contraindicated, guys. Bending at the waist should not happen. Instead, what the patient should be doing is actually bending at the knee level. Okay? Knees bending, not hip or waist bending. This is highly contraindicated. If you answered letter D, increasing the fiber and fluid intake is important. Yeah, of course, right? We want to promote the bowel and function, promoting that in order to prevent the complications such as constipation. The straining itself, when the patient is constipated, if they have low fiber in their diet, the more that they'll be straining, this can increase the intraspinal pressure, and it will also aggravate the back problems. So this is also a good intervention. Make sure that they increase fiber. Avoids, or actually the word is prevents, constipation. Prevents constipation, which is, yeah, body mechanics. Maradel, that's correct. Prevents constipation. So again, guys, the patient here is allowed to bending at the knee level, but not the hip. Hip, waist, those are red flags. All right. Let's have number 16, but before we go to do that, we are inviting everybody who have not enrolled yet to our NCLEX course at www.stancoast.com. Please drop by. If you have any questions, please message us through the email. Check on the description box below as well if you want to know more of us. And again, guys, for those newcomers, we are doing this for 90 days. We are on day 58, so we still have a long ways to go, and who knows, we will be extending this. So keep in tune to our announcements. All right, guys, let's move on to number 16. A client with severe lower back pain, leg weakness, and muscle atrophy is admitted to the ED. What diagnostic test should the nurse expect the physician to order? So your client here has severe lower back specifically. They have complaints of leg weakness, muscle atrophy, and they are now admitted to the ED. So what diagnostic test should the nurse expect the physician to order? Is it A, chest x-ray, MRI, CAT scan? Or is it B, lumbar puncture, chest x-ray, MRI, CAT scan? Or is it C, lumbar puncture, chest x-ray, myelography? Or D, myelography, MRI, and CAT scan? What do you think would be the appropriate or indicated diagnostic imaging studies? Take note of the manifestation, guys. Not just lower back pain, but they have leg weakness, muscle atrophy. Take your pick. While waiting for your answers, I will eliminate letter A. I'll start with letter A. Let's have a try on letter A. Chest x-ray, MRI, CAT scan. You know, guys, remember about the chest x-ray? Would this be an expected diagnostic test, especially that our patient has lower back? Take note about the complaint, severe lower back pain. And of course, chest x-ray, this is not indicated. This is already making this option wrong because it is not relevant for diagnosing spinal issues. Not going to help detect spinal issues. All right, let's find out about the MRI. What about the MRI and CT scan in letter A? Yeah, they are appropriate, but it will be insufficient without myelography. So this is okay, MRI is okay, CT scan is okay, but there should be an add-on to that, which is the myelography. Myelography. which is going to do more of a comprehensive assessment or evaluation of our patient. All right. So we are eliminating letter A because of the chest x-ray. What about letter B? Lumbar puncture, chest x-ray, MRI, and CT scan. Now, in letter B, there's also chest x-ray. It's going to make that option incorrect as well. Remember? That is incorrect. What else? The lumbar puncture is included in the mix. As we know that the lumbar puncture is only indicated if there is a need for us to assess the CSF, right? If we are suspecting, or if the medical provider is suspecting about infection, right? So this is also making the option wrong. These are not going to help in the diagnosis. And again, we have the MRI, CT scan. But again, this will not be sufficient. It will require myelography. What about letter C? Lumbar puncture, chest x-ray, and myelography. Again, there's the lumbar puncture and the chest x-ray, which will not help in the diagnosis. Removing that as well. We are done here with letter D. Myelography, MRI, CT scan. That is the correct answer. Well, take note about the myelography. What is really in myelography? This is going to, or these are rather, they are going to identify the herniated nucleus pulposus. And with the myelography, this is going to give us a better picture of images, especially in the spine, the nerve roots, and it will also give us a better understanding onto the extent and the location of the herniation. So our best combination here are myelography, MRI, and the CAT scan or CT scan. All right. So we have our distractors, chest x-ray, lumbar puncture. Those are not going to be helpful. Okay, let's have number 17. Before a client undergoes chemonucleolysis with chymopane for a herniated disc, what should the nurse assess for? Papain. Yeah. What do you think? Is it allergy to meat tenderizers? Allergy to shellfish? Ability to lie flat during the procedure? Or the ability to perform full ROM on the affected site? Guys, if you're not familiar, try to eliminate things that are not making sense. If you're not familiar, try to eliminate those options that would not really jive. Okay, remember about the chemonucleolysis. We are going to inject, or the medical provider will be injecting that enzyme that will lyse the diseased gel structure, the herniated disc, I should say. So I'm seeing letter D and B. Letter D, B. Okay. Let me eliminate letter D this time. Let's see. Letter D. Ability to perform full range of motion on the affected site. Guys, the question is asking, what should the nurse assess for? This is a procedure. Remember about the injection, chemonucleolysis with chymopapane. So is this something that would really eliminate possible reaction? Will that do that? Ability to perform full range of motion. We are talking about the enzyme, guys, the injection of that enzyme. Guys, take note, this is a substance that was an enzyme, rather, that is derived from something. I'll explain to you in a minute. So if you're answering letter D, Full ROM. This is not required in the chemonucleolysis. Not required. Our focus this time is basically into finding that answer which signify potential allergic reaction. Look for potential allergic reaction. That is the goal of this test question. So we are eliminating letter D. What about letter C? Ability to lie flat during the procedure. Ability to lie flat during the procedure. Guys, remember that the patient will be injected onto the site. And if they're going to lie flat, will it help expose the site? No. The patient here should be in a C position to expose that area where the injury is. To expose the vertebra. Okay, because this is an injection, right? We want to make sure that there is opening of that vertebra, so the insertion of that needle will be facilitated. You should not put the patient in a flat position during the procedure. Lie flat is wrong. Your patient should be in a C position, shrimp position. Okay, shrimp position. This will expose the vertebra, so the medication can be injected properly with that insertion of that needle. So what about letter B? Allergy to shellfish. Allergy to shellfish. Remember I said something about that this is a substance that is derived from the papaya. Remember I said that earlier, but it wasn't too obvious. Shellfish is not going to be involved here, okay? Allergy for shellfish is only going to be applicable if the patient will be getting iodine-based dyes, all right? Only applicable if iodine-based dyes are used. We are not using iodine-based or contrast media in this procedure. No, we're not doing that. And so allergy to shellfish is not something that we should be doing this time. But we will be assessing the patient's allergy to the meat tenderizer, which is basically the chymopapane. This is a derivative from the papaya. Chymopapane. This is an ingredient in meat tenderizers. And an allergy to this substance can contraindicate due to the risk of allergic reaction. All right? It is a meat tenderizer. That is the correct term. Allergy to meat tenderizer, because the substance itself is derived from the papaya, and we know that papaya is a meat tenderizer. So that's something new, right? Did you know this? Probably not. But again, our answer here is letter A. Chemonucleolysis with the use of the chymopapane. That's the clue right there. All right. Shellfish is eliminated because it's not going to involve the administration of contrast agent that is iodine-based. We're not using iodine-based substance, but we are using an enzyme that is known to lyse that diseased vertebral disc. Never heard of it. Something to learn today, right? Yeah. It's not really a popular treatment, but this is known to be very effective, guys, especially if the patient, the severity is not that bad as far as the injury, okay? It's not going to treat those severe forms of severe intervertebral herniation. It's not going to be effective to those. It will be only effective to those milder forms of herniation, not the severe ones. Okay? Let's have number 18. Which symptom indicates spinal cord compression in a client with a herniated disc at L4, L5? Is it A, lower back pain, B, pain radiating across the buttocks, C, positive Kernig signs, and D, urinary incontinence? We have our options. Which symptom indicates spinal cord compression in a client with a herniated disc at L4, L5? Is it lower back pain? B, pain radiating across the buttocks? C, positive Kernig sign? D, urinary incontinence? What a challenge today, right? If you are learning today, that's a good sign, because most of students don't really like this kind of topic, something that can be easily neglected or ignored. So if you're learning today, congratulations to you. So what's your answer? Which symptom indicates spinal cord compression in a client with a herniated disc at L4, L5? Please be careful. Let me have letter A. Lower back pain indicates spinal cord compression. Ooh, this is really going to cause some impairment in their function. This is not a joke. Okay, so if your patient only is presenting with the pain, I guess that would be minor, right? Or mild form of compression. Type of herniation, only pain. But if there is spinal cord compression, this will lead to more issues. Remember about that. Spinal cord compression is never fun. Always think of something that would be severe. All right? L4, L5. Okay. Letter A, lower back pain. Would this be a sign that there is L4, L5 involvement? We know that lower back pain is very common in all disc cases, mostly in the lumbar area, thoracic. Yes, this is very common, lower back pain. But lower back pain alone does not indicate spinal cord compression. Does not indicate compression of the spinal cord. It doesn't. What about letter B? Pain radiating across the buttocks. What do you think about this one? If there is radiation of the pain, then this is what? Gonna signify that there is nerve root involvement. Remember about that photo that I showed you earlier? Nerve root involvement. And this is a common manifestation in herniated discs. Common manifestation. Remember about that photo that I showed you earlier, that the gel-like structure and also the annulus is actually pushing into the nerve root? Yeah, this can lead to the radiation of the pain into the buttocks, especially if it is involving the L4, L5, right? But common manifestation. What about letter C? Positive Kernig sign. Remember about this? Positive Kernig sign. This is a indication of meningitis. This is a totally different condition, guys. We are eliminating this one. Eliminate positive Kernig sign. What the patient manifests in meningitis is that the Kernig sign, rather, when they manifest the Kernigs, they're going to have that severe stiffness in the hamstring muscles. Severe stiffness in the hamstring muscles. Yeah. So Koenig sign is eliminated backstage. It is unrelated to the herniated disc symptoms, not related at all. So urinary incontinence, you got your bladder function that is now affected. There is going to be loss of bladder and bowel control whenever there is spinal cord compression, especially if it's affecting the L4, L5. Okay, so our patient definitely need to have immediate surgical procedure, make sure that there is administration of those medications that can decrease the swelling into the area, to decrease compromise of the blood supply into that L4, L5 area. Yeah, we need to do that in order to prevent permanent damage. Okay, urinary incontinence is a serious symptom when there is involvement of the spinal cord. All right. Alrighty, I hope that you're learning with this one. Answer is letter D. Let's have number 19. I think I still have number 19. I think this would be the last. How should the nurse describe a herniated disc to a client? This was the question from, I can't remember the name, but he asked me earlier. I think he might be gone already. I haven't seen his name popping up. But anyway, the question is, how should the nurse describe a herniated disc to a client? Is it A, the disc slips out of alignment? Or is it B, the disc shatters and fragments place pressure on nerve roots? Or is it C, the nucleus tissue itself remains centralized and the surrounding tissue is displaced? Or is it D, the nucleus of the disc puts pressure on the annulus, causing pressure on the nerve root? And I already described this earlier, way before. So what is your option in this question? How should the nurse describe the herniated disc to a client? Will that be A, B, C, D? Your answers, or your answer rather. Anita answered letter D. Also, how do you say your name? Is it Poupée or Poupette? Brumeri? I'm sorry if I mispronounced your name. Chi-Chi answered letter A. Guys, pick that answer that actually would be complete in its description. Pick that answer that will describe entirely what is going on in the herniated disc. Okay, good. Thank you. So again, guys, select that answer that would completely describe what is exactly going on in the intervertebral, herniated intervertebral disc. Okay. Herniation. Take note about the word herniation. If I had mistakenly said something about slipping, I apologize. If I mistakenly mentioned slipping, then I apologize. But here, you describe what is exactly going on in the herniation. What would be that? Okay. Let's go back into the photo. I'm giving you a chance. Take a look into the herniation. Here is our gel-like structure. Remember about this. And then we have our annulus. And then we have our nerve root over here. Okay, so what would be your answer this time? Going back into this photo. Again, this is the disc right here, that gel-like structure. And this is the annulus, the one in the blue color. With this protrusion of the annulus and also the gel-like structure, causing pressure into the nerve root. So that's actually herniation itself. It's not the slipping. Going back into that question right now, what would be your final answer this time? Will that be A, disc slips out of alignment? Or will that be B, the disc shatters and fragments, place pressure on nerve roots? Or will that be letter D, the nucleus of the disc puts pressure on the annulus, causing pressure on the nerve root? Or is it C, the nucleus tissue itself remains centralized and the surrounding tissue is displaced? Is it really true? Displacement of the surrounding tissue? Okay, not quite. So if you're answering letter C, that is incorrect. Letter C is incorrect. Why? Because in letter C, or rather in a herniated disc, the nucleus does not stay centralized. No, the nucleus is not staying centralized. It moves out and it will press onto the surrounding annulus and also the nerve roots. So this is false. What about letter B? The disc shatters and fragments place pressure onto the nerve roots. Are there any fragments? Are there any fragments? No, there is no fragmentation because the disc will not shatter. It is the nucleus just herniating. Remember about the protrusion? These are two different things. There is no shattering. This is a gel-like structure. It will herniate. So letter B is wrong because of the word shatters. There's no fragmentation as well. If you answered letter A, disc slipping, again, if I said the word slip earlier, I apologize, that is incorrect. The disc slips out of alignment is incorrect. It does not slip. It's herniating, meaning the nucleus is pushed through the outer layer, or it pushes the annulus, which will cause pressure into the nerve roots. Okay, so we have our answer, which is letter D. The nucleus of the disc puts pressure onto the annulus, that bluish color signifying the annulus, right? And this will eventually cause pressure onto the nerve root. So here the patient will manifest the pain, and also some weakness, okay? But if the herniation, or if there is now compression, especially a complication wherein the spinal cord is involved, then that is going to be much more severe. It can lead to control problems in the bowel and the bowel and bladder pattern, especially with the L4, L5 level. Yeah, so those are the more severe forms of the herniated disc. Okay, guys, our answer here is letter D, just to emphasize that. So, guys, that's the end of our lecture today and also our exercises. I thank you again for your participation. I hope that you are learning new things today, and I hope that you can apply this in the NCLEX. And I'll see you again tomorrow at 9 p.m. Eastern Standard Time. And I'll see you again. So you all take care. Okay. If you have any issues regarding the, the logins, especially if you had signed up for the course. I've been advised to tell you that if you are having issues, make sure that you're logging in with the same ID. When you sign up for the course, make sure that you are using the same ID that you used during the purchase, okay? And also make sure that you are using if you're using the iOS device, make sure that we are actually recommending for the Chrome or the Mozilla browser to access the website, okay? Do not use Safari this time. It's not known to work with the program. And so make sure that this is compatible. So again, Chrome or Mozilla browser. And again, avoid creating multiple tabs because this can possibly cause you to be logged out. So make sure you only have one tab at the time when you are reviewing. All right. So if you have any more questions regarding the course, let us know. You can send us a message here so I can forward your query to the team. And just to let you know, guys, I don't have control into the exams. I don't. I'm only responsible for the lecture this time. So if you're going to ask me about logins, I don't have any control over that one. So if you have issues, you can tell me so I can forward the message. Or if you can email them directly as well. So again, that's it. Again, thank you, everyone. You take care, and I'll see you again tomorrow. Bye-bye.